Right? Dr. Manju is a faculty at LVPI Hyderabad, and she would be talking about how to diagnose and manage ocular myasthenia gravis, which is a condition which is confounding, I think, to most of us. Unless you have some proof there, it is a difficult condition to diagnose. Over to you, Dr. Manju.
Thank you so much, and thank you AIOC and the chairpersons for including my talk in this session. So I'm going to talk of a topic which is generally of grave concern to us, which is ocular myasthenia gravis. And this is because it's important that it's to know that it's a diagnosis of exclusion and that we need to rule out sinister causes before considering treatment, starting treatment in this. So I'm going to take you through some of the myasthenia and also coupled with a few cases as well. So basically, as we know, it's an autoimmune disorder of defective transmission at the neuromuscular junction. And ocular myasthenia gravis is isolated extraocular muscle involvement for more than or equal to 2 years. The incidence is 1.7 to 30 cases per million, and the prevalence is 77.7 cases per million. This is US data. Of this, 10 to 15% of all myasthenia gravis are pediatric, and juvenile myasthenia is 1 to 5 cases per million. So what's important to also know is that ocular myasthenia in juvenile is 10 to 35%, and the rate of progression of ocular to generalized generalized in juvenile is 8 to 33%. So as we know, the pathogenesis involves binding of the acetylcholine receptors by the autoantibodies, which are the IgG autoantibodies. There is complement-mediated damage, and there is destruction of the ACH receptors on the muscle membrane. In addition, there's also receptor muscle-specific kinase, that is the MuSK receptors, which are also affected by the autoantibodies, and also the LRP4. This is more in pediatric myasthenia gravis, that is a low-density lipoprotein receptor-related protein, and the agrin. There's also a role of thymus in myasthenia gravis. That is when there is thymic hyperplasia, we see there's autoreactive T cells which cross-react with the antigen and produce autoantibodies. So thymectomy has a role in ACH receptor positive myasthenia. So this is kind of a brief overview. We'll go back and forth, but we'll look at a case once. So this is a 39-year-old female. She came with drooping of the right eye. She did give history of variability, and on detailed history, we did come to a conclusion that it seems to be more towards the end of the day. She also had associated diplopia, which was noted for 15 days. The vision was good in each eye. I'll come to the 9 gaze, but she had limitation of elevation, also a little bit of adduction and abduction. And after ruling out our standard cranial nerve paresis or common differential diagnosis, she was tested with pharmacological testing. Her ACH receptor antibody titer was positive. There was no thymoma on HRCT. And she was started on myastin, 60 milligrams, with tapering steroid regimen. So this cycle was repeated twice. And as we can see here, she has the ptosis. There is limitation of elevation in all straight up gaze as well as the right and left up gaze. A little bit of adduction, abduction limitation. She had a left hypertrophy of 14 and an esotropy of 12. After starting her on a combination of mestinon as well as tapering steroids, she did improve, but that mild ptosis, which you can see in the primary position, the center photo, persisted. She was orthotropic, and this went on for 6 months, and then she was switched on to immunosuppression, that is steroid-sparing Azoran, 50 milligram twice a day, and then she's completely symptom-free at a further follow-up. So this, I'm showing a follow-up of 1 year, but all these patients, be it adult onset or juvenile, are going to need pretty much a very long-term treatment regime. So myasthenia is something which at some point, after the diagnosis, we need to explain very carefully to the patient that what it involves over their lifespan. So what's important is the variability in the clinical features. That is the variability of ptosis, the diplopia, the limitation of ocular motility, and there is no specific pattern with regards to which cranial nerve palsy it may mimic, stimulate, or it may not fit into any, and also the presence of Kogan-lit twitch. Just sitting at the office, we can do simple tests like fatigability when we see the doses increasing on prolonged upgaze, an ice pack test, or a rest or a sleep test. And the third test is quite important even in children because they may not tolerate an ice pack or may not cooperate for a fatigability test. The pharmacological tests, as we know, are the edrophonium, then the anti-ACH receptor antibody titer, anti-MuSK antibody titer. Usually we order a combination of both, and the nerve fiber stimulation, that is the electrical test, either the repetitive nerve fiber, where there's a decremental response after 3 to 5 stimulations, or a single fiber electromyography. The management algorithm, as we know, is either the pyridostigmine in or combination with steroids. At some stage, a steroid-sparing agents like a mycophenolate, azathioprine, or a tacrolimus should be considered. So also plasmapheresis or IVIG, this is individual case-based, and depending on the response that patients do show us. Thymectomy is more, I would say, valuable as a treatment option in seropositive ACH receptor test. So here, by knowing all this information, we kind of know that there is variable sensitivities of the various tests in literature. There is different presentations as well as progressions in seronegative as well as seropositive cases. And also the effect of various therapies may or may not be the same in all the patients. So we tried to do a study and looked at 285 suspected myasthenia patients, 121 confirmed to be myasthenia based on either of the diagnostic tests. I've written the inclusion-exclusion criteria. And looking at these tests, we came to know that the age of presentation was slightly higher in males. So also the gender was more noted in males. A small percentage was pediatric, and most were bilateral cases. Then looking at our results, ptosis was the most frequent. Limitation of motility was also noted in 61% of the cases, and generalization more in seropositives was noted in 13% patients. So in this, we come to know that the edrophonium or the neostigmine test in our study was 8% observed to be positive in this cohort of patients, and also that pyridostigmine and steroids was the most used treatment modality in managing these conditions. So also a small number or a sizable number, I would say, needed immunosuppressions. So here we come to know that the pyridostigmine with steroids gave a 61.5% improvement. Thymectomy patients tended to be poorly controlled. So I've not gone into every detail of the study, but we've got fairly interesting findings. I'm just going to wrap up in the next 1 to 2 slides. So there are major differences we note in adult onset versus pediatric onset myasthenia, both with regards to ethnicity, the myasthenia conversion that is more noted in adults than children, the seronegativity, which is fairly common in children, and also the EMG findings. This is gold standard in both, whereas in children, we tend to have a step-ladder management approach with using steroids than steroid-sparing agents. And there is more remission in prepubertal myasthenia than postpubertal. So again, I'll quickly run through this case. This simulated a fourth nerve palsy, but this patient was already on treatment. He then came with variable ptosis when we started tapering the Visalone, and then needed immunosuppression over time to have his entire disease under control. So this really needs a lot of individualized approach. And to conclude, myasthenia is a mimicker. Congenital prepubertal is often seronegative, and EMG is needed to prove. Genetic diagnosis is important. I didn't go into the genes, but there is a number of genes, especially in the pediatric myasthenia. A step-ladder approach, and it's important to know of refractory cases and early switching to immunosuppressives. This disease requires a multidisciplinary approach, so it's not ophthalmologists, but also the physicians that need to be involved. I'll conclude with this. This is a slide where I'd like you to save the dates. July 20 to 22nd, we are having an international pupil colloquium at LV Prasad Eye Institute. I'll share the details later. Thank you so much.
Thank you, Dr. Manju. We have some time, so we can take a couple of questions for the first 3 talks, if there are any. Okay.
Dr. Manju, I just have one question to you. When do you recommend that other antibodies for myasthenia, like agrin and There are
Okay,
so many
the-
newer
yeah,
antibodies which
so
are in the literature.
The LRP4 more so in any patient presenting with myasthenia less than 18, because these are more often seen in the pediatric or the juvenile myasthenia. As a routine for adult myasthenia, I would do both ACH receptor and anti-MuS. It kind of comes as a package test which is offered by most laboratories around our institute as well. But we can talk into most labs for getting it done. So both these for sure. And then switch to electrical tests to try and get a confirmatory or a gold standard. I don't routinely look at LRP4. It's not easily available in all labs.
Dr. Sachin, your comments, please.
Yeah, I agree with that. LRP4, I have very rarely used it. Between a combination of acetylcholine receptor antibodies and single fiber EMG, you'll get your diagnosis in most cases. The one thing that I emphasize is the rest test, or the question asking your patient, do you have ptosis upon waking up early in the morning, is probably one of the most sensitive questions you can ask.
Yep.
If the patient has myasthenia and say, it's not there when I wake up in the morning, then it kind of supports the diagnosis. But if they wake up with ptosis, it's unlikely to be myasthenia.
True.
Sure, please go ahead.
How do you diagnose myasthenia gravis? Right now, acrophonium is not available. How do you test? Do you test with the neostigmine?
We do neostigmine test, yes, in adults. So it starts with a 10 milligram. I can tell you the entire. Oh, so the diagnosis, so that we are doing in cases of myasthenia which have the ptosis, to look at improvement of the ptosis after injecting the neostigmine. It's 10 milligram.
Inject with atropine or without atropine?
No, we inject without atropine, but we have an anesthetist standby. We do it in the operation theater. Thank you.